Good afternoon. Thank you very much, Laura, for this kind introduction. I would like to thank the organizers for inviting me to be part of this important symposium. In the next 8 minutes, I was asked to address long-acting antiretrovirals for special population. Let me tell you, it was not an easy task because there is very scarce literature about it. These are my conflict of interest disclosures. So first question is, who would benefit from long-acting agents? First of all, virological suppressed persons with optimal adherence. The typical patient you see in your clinic that comes and you ask him, did you take your medicine? Oh, doctor, don't be mad on me. Last Wednesday, instead of taking it at 9 o'clock, I did it at 10, but I promise it will never happen again. Well, this type of patient will be adherent to any regimen that you prescribe. Also, I think about naive patients diagnosed in the context of acute opportunistic infections that are not able to swallow pills. And my task today is to discuss how to treat individuals due to concomitant diseases, lifestyle, and/or socioeconomic conditions. Let me see. So who are those special populations and what do they think? Considering the wide range of population that would benefit from long-acting, it goes beyond the already known key populations, a term which focus on high-risk behavior, because the special population include transgender persons, psychiatric conditions, people in nursing homes, people in jail, homeless, individuals that are just unable to swallow pills or have simply pill fatigue. Scarce data are available about their expectations. I found this interesting paper done at the Women's Interagency HIV study, in which they conducted interviews over female living with HIV and female that were HIV negative. And basically the main message was that participants identified the subpopulation of women who could most benefit from long-acting regimens over daily pills. This included young people, women with childcare responsibilities, people with adherence-related psychological distress, individuals with multiple sex partners, and people facing structural insecurities such as homelessness, which is an important population we need to take in account. Usually, women are underrepresented in clinical trials, and this is not the exception. At Fundación Huésped, we performed an online poll survey to assess preference for long-acting injectable over daily pills and willingness to use it in Argentina. We got 1,600 respondents. Half of them, almost half of them were people living with HIV, and the other half were HIV negative or just did not disclose the HIV status. As you can see, among people living with HIV, 91.5% preferred injectable long-acting ART over the oral pills, being the gay, bisexual, and queer cisgender men the highest rate. Among the HIV negative, they were asked what would you prefer regarding long-acting PrEP, and the numbers are lower, as you can see, 68%, mainly among heterosexual cisgender men. Well, with the association that we found, non-statistically significant, but still important to mention, were that among people living with HIV, the willingness to receive long-acting ART was positively associated with being younger and with higher educational level. And among the HIV negative regarding PrEP, it was positively associated with having a good experience using injectable medication before. So these things have to be taken in account when we plan for the future, when we go to the implementation science in order to see what is the best way to address these populations. For more data, you can look at the poster EPB 185 presented at this conference. A special chapter for transgender women. Long-acting CAP is recommended for gluteal injection only, as well as long-acting ribavirin. If using injectable PrEP or treatment, it's important to know whether a transgender woman has silicone prosthetic buttocks. If CAP is injected into the silicone, it will collect inside the silicone and not penetrate body tissues. For these patients, oral tenofovir-based PrEP or oral ART may be the best option. At this conference, some new information has been presented regarding the injection in the ventral tide, so it could be that this is no longer the latest news. We need to confirm these findings. Interesting enough, in our cohort, we have a cohort now, over 500 transgender women that we are following. At that time, when we prepared this slide, were 466. 52% had silicone injection, so almost half of them have silicone injection, and this is part of the picture. Looking for some evidence, I looked back at the poster presented by D'Amico at the virtual conference in 2020, in which compassionate use of long-acting cabotegravir and rilpivirine for patients in need of parenteral antiretroviral therapy was performed. Physician could request this compassionate use under an expanded access program. The key criteria for granting requests included the need for parenteral therapy, advanced disease, absence of key mutation associated with resistance to cabotegravir or rilpivirine, and established retention in care. All patients received the loading dose and then every 4 weeks. If you look at this population, you will see that it's a fairly advanced population in which 2/3 of them, here I can show you, 2/3 of them, let me see if it is work, yeah, had previous AIDS diagnosis. I'm doing something wrong here, no? Sorry. So 2/3 of them had previous AIDS diagnosis. You can see here the median CD4 count was 100. Detectable viremia was present in 80% of the population. But I would like to drive your attention to the bottom part of the slide, in which you can see the primary reason for compassionate request. Psychological, 15, physical challenges, 8, and malabsorption, dysphagia, and limited cognitive skills are the other reasons that were mentioned. When we go to the results, you can see that 80% of the patients enter the compassionate use program, even 10 without oral lead-in, with detectable viremia, 80%. This particular subpopulation had a CD4 cell count median of 61 cells. At the time of this analysis, 57% achieved virological suppression with cabotegravir and rilpivirine. It's not a high number, but it's, if you recall that 80% were on virological failure, 57% were rescued with this regimen. And regarding coming back to the candidates for long-acting ANT, we are eagerly awaiting the results of the Latitude study, the ACTG 59. This is a study devoted to patients with suboptimal adherence. So patients, you have to be non-adherent in order to be recruited for this study. 350 patients will be included in this study, and patients will be followed up to 180 weeks. The inclusion criteria, the study is still including patients, is to be 18 years or older, having at least 6 months of antiretroviral therapy behind. Screening HIV had to be greater than 200 copies, and there is evidence of non-adherence defined as having poor virological response within the last 18 months or lost to clinical follow-up within the last 18 months with non-adherence for at least 6 consecutive months. So we are really looking forward to see the results of this study, because this would be the opportunity to provide direct observed therapy, DOT, for a population that otherwise would be impossible to do with a single stable regimen pill once a day. Regarding the knowledge gaps, there is an interesting paper that has been published by Charles Felix and co-workers from the long-acting extended release antiretroviral resource program, the LEAP, in which they looked at the needs for infant, children, adolescents, and pregnant and breastfeeding women, and they defined some research priorities that I will share with you. For pregnant and breastfeeding women, I quote them, studies of investigational agents in non-pregnant women should allow those becoming pregnant during the trial to remain in the study and on the assigned study drug with additional informed consent, unless there is clear justification for exclusion. Pregnant and breastfeeding women should be considered eligible for active enrollment in clinical trials unless clear justification for exclusion exists. And of course, this has to be done with additional monitoring of maternal, pregnancy, and infant outcomes in order to better understand the consequences of these actions. For neonates, neonatal washout studies are needed to describe the disappearance of the drug present at birth after in utero exposure, following by dosing studies to describe safety and pharmacology in neonates and young infants to allow the use of novel formulation for this neonatal and young infant prophylaxis and early treatment. And the same holds true for children, adolescents, etc. As general recommendation, acceptability studies should be done early in the development of long-acting formulations to understand the attitudes of care providers, ourselves, children or of different age, and their parents are pregnant and breastfeeding women. And this consensus calls for early inclusion of kids in trials as long as the safety information from adult trials is obtained. Don't wait to include children in the trials until the adult trials are done, because this is wasting time, precious time for our kids and our pregnant women. So in conclusion, long-acting agents are a game-changer option for treatment and pre-exposure prophylaxis. Most in-need population might benefit from these new options. Logistical challenges that have been described by Beatrice need to be addressed to make it happen, but it could widen the access gap if equity is not considered from scratch. A network of navigators, maybe even peer navigators, is needed to reach and support some of these left-behind populations. Research priorities include populations with different vulnerabilities: pregnant women, children, youngsters, transgender, people in jail, psychiatric patients, people in nursing homes, and homeless individuals. And as a bottom line, but as a main message, nobody should be left behind in this new treatment paradigm. We cannot accept a no for our patients that are in the worst socioeconomic situation, or eventually with dementia problems or any other issues that put them aside of the quote-unquote common patients. So with that, I would like to acknowledge the support of our translational team, particularly Dr. Denise Aristei, who helped me to prepare this presentation. I thank you very much for your attention.
Muchísimas gracias, Pedro.